We've absolutely all been there, right? You wake up with that scratchy feeling in the back of your throat, the sudden fatigue, the awful sniffles. But when you're sitting on that exam table in the doctor's office, what exactly is going through their mind? How do clinicians actually decipher the clues your body is giving them to evaluate and treat an upper respiratory tract infection? Well, grab your magnifying glass, because in this explainer, we're stepping into the shoes of a medical detective to decode this everyday medical mystery. Okay, let's dive into this. The absolute ultimate puzzle in literally any clinic during the winter months is distinguishing a viral infection, the kind that just needs time and tea, from a bacterial infection that urgently requires antibiotics. I mean, it sounds simple enough, but clinical presentations overlap so much that it takes a really strict, systematic approach to crack the case. And getting it right is absolutely crucial, because giving antibiotics for a viral cold, it does literally nothing to help you, and overusing them causes massive, massive problems down the line. What's truly staggering about these infections is just the sheer volume of them. To put this into perspective, as an adult, you can expect to get about 2 to 4 of these every single year. But children? Oh man, kids get a whopping 6 to 10 of these infections annually. That is almost 1 a month during the school year. Because of this incredibly high frequency, mastering the diagnostic process isn't just some academic exercise for doctors, it's their daily reality. To solve the mystery, we obviously need to define our crime scene first. An upper respiratory tract infection, or URTI, involves the structures at or above your vocal cords. We're looking mostly at viral culprits here, things like rhinoviruses or coronaviruses, which heavily peak in the fall and winter. For the clinician, the golden rule here is the timeline. These symptoms typically resolve within 14 days. Anything longer, and the plot thickens. So when a patient walks in, a clinician doesn't just guess. They execute a highly strict evaluation flow. First, they do a targeted review of the head, eyes, ears, nose, throat, and pulmonary systems. Second, they evaluate recent exposures and vaccination status, like have you been traveling, have you been around sick classmates? Third, and this is a big one, they hunt for red flags. And finally, based on all of that gathered evidence, they order highly targeted labs. Actually, let's pause on those red flags for a second, because before a doctor even begins to worry about whether you have a standard cold or strep throat, they are scanning for these. These are urgent, blaring alarms that point to life-threatening causes like epiglottitis or severe COVID-19. If a patient presents with symptoms that were improving but suddenly crash, or if they show trismus, drooling, a muffled voice, or signs of respiratory distress and sepsis, the detective work stops right there and emergency intervention begins immediately. Assuming there are no red flags, it's time to meet our suspects. Let's introduce our first patient. This is a 16-year-old male. His chief complaint is a sore throat, runny nose, and a cough that's been lingering for about 3 days. When we take his history, we note that the onset was gradual. He has a mild headache, a low-grade fever of around 37.8 degrees Celsius, and a clearly runny nose. Plus, he's been hanging around classmates who also happen to have colds. Now, contrast him with our second patient, a 14-year-old female. Her chief complaint is quite different: severe sore throat and fever for 2 days. Her symptoms came on suddenly, out of nowhere. She has a high fever of 39 degrees Celsius, fatigue, extremely painful swallowing, and here is the absolute most crucial clue for any medical detective: she completely lacks a cough, absolutely no cough and no runny nose. And this brilliantly illustrates the divergence in their physical exams. When we look at the 16-year-old boy, he basically just has mild throat redness and swollen nasal passages with clear discharge. His breath sounds are totally clear. But when we look at the 14-year-old girl, the clinical clues really start to pile up. She has enlarged erythematous tonsils with white exudates, palatal petechiae, those are tiny red spots on the roof of her mouth, and exquisitely tender cervical lymph nodes. At this point, the doctor might turn to laboratory studies to lock in their suspicions. Non-specific routine labs, like a complete blood count, or inflammatory markers like ESR and CRP, can help determine the overall severity of a disease. But to really crack the case and find the exact etiology, doctors rely on disease-specific tests. If the physical exam heavily points toward a bacterial infection, they're going to use a rapid strep test. If they suspect specific viruses, like influenza or COVID-19, they'll order NOTs, which are those highly accurate molecular PCR tests. So, based on all the clinical evidence we've just gathered, let's play detective. What's your diagnosis? Well, for our 16-year-old male with the gradual onset, the cough, the runny nose, and mild throat redness, literally all the evidence points to a viral URI, the common cold. But for our 14-year-old female with the sudden high fever, tonsillar exudates, and zero cough, the rapid strep test confirms she has streptococcal pharyngitis caused by group A streptococcus, a definitive, undeniable bacterial infection. The mystery is solved, which means treatment can finally be correctly tailored to each patient. For the 16-year-old with a viral common cold, the treatment is entirely supportive. Antibiotics will not touch a virus. They are totally off the table. Instead, the prescription is rest, aggressive hydration, paracetamol for the fever and pain, a saline nasal spray for the congestion, and honey for the cough. With this supportive care, his body is going to clear the virus naturally, and symptoms will typically improve in about 5 to 7 days. The 14-year-old girl with streptococcal pharyngitis, however, is a totally different story. This is a confirmed bacterial infection, which means targeted intervention is absolutely necessary here. The doctor must prescribe antibiotics. And this isn't just to make her throat feel better faster, although it will, usually within 48 to 72 hours, but rather to eradicate the bacteria completely from her system. So the crucial point is, it isn't just about choosing the right weapon, it's the duration. The absolute first-line defenders against Group A strep are amoxicillin and penicillin V. For amoxicillin, children might take 50 milligrams per kilogram once daily, while adults would take a 500 milligram dose twice daily. But regardless of the specific dose, or whether you choose amoxicillin or penicillin V, both of these first-line treatments require a very strict 10-day regimen to ensure complete bacterial eradication. But hey, what if our patient is allergic to penicillin? A good detective always needs a backup plan. In the case of an allergy, doctors pivot to alternative antibiotics like azithromycin or clarithromycin. What is genuinely fascinating here is how the treatment timeline shifts based on the drug. While clarithromycin still requires that full 10-day course, azithromycin is much, much shorter. An adult takes a 500 milligram dose on day 1 and then 250 milligrams daily for just days 2 through 5. Now, you might be wondering, why does this matter so much? Why do doctors care so deeply about a strict 10-day course of antibiotics just for sore throat? Well, if bacterial strep throat is left untreated or even just partially treated, it can lead to devastating long-term complications. The bacteria can cause rheumatic fever, which literally permanently damages your heart valves. It can cause a peritonsillar abscess in the throat that requires surgery, or acute glomerulonephritis, which severely damages the kidneys. That is exactly why targeted, complete treatment is so vital. Because of those intense risks, the practical advice given to the 14-year-old is very specific. First, she must complete the entire antibiotic course, even if she feels perfectly fine after 2 days. Do not stop early. Second, she needs to stay home from school for at least 24 hours after starting the medication so she isn't contagious to her friends. And finally, here's a really great real-world pro tip. She needs to literally throw out and replace her toothbrush after 1 to 2 days of treatment so she doesn't accidentally reinfect herself. And there you have it. The mystery is officially solved. By looking closely at the clinical presentation, doctors can protect you from the harms of unnecessary antibiotics while delivering targeted, life-saving treatment when you actually need it. But as bacteria continue to evolve and antibiotic resistance grows worldwide, it begs the ultimate question. In the medical mysteries of the future, will our current diagnostic clues still be enough to crack the case? Thanks for joining me on this explainer. Stay healthy and keep learning.